Hello, this is Glenn Krause from AE and Associates. Today we're starting with our new podcast. It's called Clinical Documentation Intelligence Podcast, also known as a podcast for the CDI. And I have the privilege today of having Dr. Daniel Aragon. He's our R3 resident, going to be finishing up his trained residency. And Doctor?
Hey Glenn, thanks for having me.
Sure.
I'm excited to be here. So I'm originally from Mission, Texas, in the greater McAllen area. In deep South Texas, think about San Antonio, and 3 hours south. That's why I say deep South Texas. I was born and raised here. Went to university down here, what was known as University of Texas Pan American. I went to medical school at University of Texas Medical Branch in Galveston.
Yeah.
Did an MBA around there at the University of Houston Clear Lake, and then decided to come back home to my area, to UTRGV, to do my internal medicine training. I'm currently accepted into the University of Rochester Critical Care of Medicine program, so I'll be moving there later on this summer.
Oh, so you'll be enjoying the summers much more than down in Texas, won't you?
Yes,
I
definitely.
mean, I can remember being down in your area, McAllen area, in the summertime. Wow, getting off the plane was unbelievable. So, yeah,
Yes.
so I think we connected on LinkedIn. I believe, Doctor, there was some post about, I think, physician advisor had posted something about, if I recall correctly, about physicians getting receiving education and documentation, but way over your head. I think that was what the gist was, wasn't it?
Yes, definitely. So someone had posted something about whenever they were speaking to physicians about clinical documentation integrity and informatics, to not use jargon,
Yeah.
that is common for them but uncommon for physicians who practice on a daily basis. So it really resonated with both of us, and we met, we connected
Yeah.
through the comments there.
And so listen. So as a resident, I'm going to kind of pick your brain a little bit because I believe we're thinking along the same lines from a resident documentation perspective. And I know working with residents at UMC Las Vegas that the residents, they want to do right. They want to learn. I mean, I once had three R3s when I was discussing some cases with R2s, and they were standing behind me, and they said, "Why didn't we get this training while we were in our earlier program?" And I said, "Well, what I can help you." And he says, "Well, we're R3s." And I said, "Oh, I can still help you." He says, "Do you give crash courses in documentation?" This is a true story here. And I said, "Well, yeah, I can probably do that in a week." "Oh no, we're leaving tomorrow." So no, that wasn't possible. But I'm glad you're here. So I think the first thing we want to discuss, if you don't mind, is as a resident, you have experienced some documentation training that you indicated in your LinkedIn post or comment that you have expressed some dissatisfaction with. What was the training that you received, and how specifically did it not meet your needs and desires? Because I noticed you wrote in there, you said in your post, you were wondering when you were going to get out of there, looking at the clock.
Yes, definitely. So, in terms of that, there's not. So let me just take you through what
Yeah,
happens.
tell me.
Essentially, it all starts whenever you start being onboarded into residency.
Yes.
The 2 weeks before July 1st.
Yep.
So those 2 weeks you go through a lot of trainings, different type of trainings, and one of them is the clinical documentation. Guess who gave it?
Who?
I did.
You
I
did?
did.
Did you?
Yes. So
Great.
the reason was because my notes were up to par to what the program wanted.
Oh yeah.
But now that I think about it, and
Yeah.
that I'm being more exposed to people like yourself, I realized that the reason faculty and the team thought that my notes were good were because they were able to explain the reasoning to the attending of what the plan was. So it was more for the attending and not so much for the clinical documentation integrity, not for the billing department, not for the medical
Coding.
coders. Um, so so it wasn't for that. It was mainly because it was a well structured and it helped the attending know exactly what was going on.
That's right. Critically important.
Exactly. So it's great as a learning, like if you're when you're learning medicine, right? But it's a very time consuming process. And as an intern, you spend a lot of time on your notes because that's kind of how you're evaluated on. And then also on rounds, right? Right, of
Right.
course.
Yep.
So, so I had during my early second year, I taught the first years, and then again during early my third year, they asked me to present it again. So that's the first exposure as an intern that you have to clinical documentation. And one, it's not guided towards medical coding, medical billing, as we see in real life, right?
Yep.
So that's the first, I would say, flaw in the system. Second one is that during the first month, there's this boot camp of so quote unquote boot camp of courses that our attendings is teach us on specific subjects that we'll commonly encounter, and one of them is the medical documentation again.
Okay.
So this is now from a faculty perspective of what they are expecting from us. And again, it's based on what the attending wants, right? It's not based on, hey, this is how it's going to be in real life once you graduate. So that's the second exposure. And honestly, in retrospect, being naive, we were like, oh, this is great, right?
Yeah.
But then later on during the year, so these past 2 years, I've seen that the hospital, it comes to a point in I would say February, March, comes to a point in which the medical coding department realizes, hey, we need to address this. They're not documenting things appropriately, although our attendings don't say anything about it. But the coders do see certain issues that should be improved on. So then that's when they come, and it's more of a reactive thing and not so much of a proactive
Yeah,
thing.
I see that.
And they try to give us this 1 hour crash course on how we should be documenting appropriately. While for the past 6-7 months, the interns have been barely gaining experience and speed on the documentation, and then come March or February, you want them to switch up again. So that was the moments that I was like, okay, this is just destroying everything that I have worked upon up to now.
Yes.
And then now you're asking me to restart all over.
Let me ask you a question, Dr. Aragon.
Yeah.
I were the coders providing information that was necessary for coding and not so much communication of patient care? Is that what you found when you went this crash course with the coders?
Yeah, sometimes they had some jargon in there. I don't exactly remember what type of jargon. I just remember because you don't remember the specifics. You just remember how you felt, right?
Yeah, I know.
So I completely felt lost. I'm like, I'll be here because out of respect for them.
Yes, sir.
But I'm really not gaining much from this. All I'm gaining is that what I've been doing is not correct.
And and one thing I think you may agree is that, I think you hit on an excellent point. What you said was that each your attending grooms you or provides information as to how they want the documentation to appear. So I listen to a lot of YouTube videos, particularly for residents providing case studies to their attendings, and what to do and what not to do, and not to give too much information about the past history for the last 20 years, okay? And get right to the point. I think that's, and now that you have different attendees, you may change services, making your rotation into different specialties like ER, and then maybe psych if you're going to psych. Everyone has a different way of communicating. You're communicate, you're documenting for their style, and then when you get out, you're not sure what is the correct way, right? Am I thinking correct?
That's exactly correct. Yes. So I was recently in an endocrinology rotation,
Right?
and there would every day for sure I would have a different attending. Um, Sometimes like half day in the morning I was with one attending, and in the afternoon I was with another attending, and that was the hardest thing, learning or remembering the style of documentation each attending wanted
That's
specifically.
right. Because that's how you're getting graded, as you said, right? Part of your
Exactly.
documentation and your presentation of the patient as you make rounds and then you come together. They want it succinct, right to the point. Everyone want that must be challenging, I would think.
Definitely, yes. And I think that's one of the biggest challenges, even moving forward after intern year.
So that just brings me up to another point I think we were discussing. So I feel that the CDI specialist can play a vital role in providing that information, baseline, fundamental documentation, because that's what I try to do with residents when I work with them to say, okay, regardless of who your attending is, this is the standard that you should follow. Like, chief complaint, history of present illness, at least 4 elements. Otherwise, you don't have a patient story. And then the next physician assuming care, another resident coming in, starting all over again because they don't know where the patient's been because you haven't, not you specifically. What are your thoughts on this? Could CDI help residents in terms of, I think, fundamentally having a strong appreciation for what the standards of documentation are, because Medicare has defined what complete and accurate is. Doesn't really matter what service you're on. They define complete and accurate documentation, and I'll be happy to share that with you after. Okay. Uh, what are your thoughts on them playing an integral role in helping residents get prepared? Because I just like I mentioned earlier, I started working with the head of a medical program, a hospice program with the residents. Why? Because I found that when I found these two residents asking for a crash course, that's not a good time to learn when you're going to be a hospice a week later. Right?
Yeah,
I always say practice with someone else's revenue, not your own. Right?
exactly.
So what are your thoughts on maybe CDI taking the lead in that?
I think it would be it's very important, and I think it would be very helpful in terms of our training and our growth. Residents in general are very appreciative and receptive to feedback, um, because we know in the position that we're in, we don't know everything, and this is the practice for real life. And we would appreciate anything that would help us later on or for the rest of our lives and for the rest of our careers. Um, but I think that that feedback should not be 7 months after you started.
That's right. That's what I'm thinking. We started, I think your interesting point because what the director said, I like you to talk, that what's the first day when they get crammed with 20 people up there? That first day, what's that first day of the program? They have they have compliance there, and they have coding there, and they have patient safety there, and you have HIM there about HIPAA and all that. So
Exactly.
obviously you're getting bombarded with information. So the director asked me, "Would you do a short kind of a summary of CDI and documentation?" And I said, "Well, I think it would be good to go up and discuss how not to document, right? How
Yeah.
how not to document." And it was well received. So I believe, as you said, 7 months after the fact is way too late. We should be really working with the residents on day one. Well, not necessarily day one because you can't really learn. And, you get your badge and then you go into this room we had 220 residents in there. Holy mackerel! I couldn't believe the number of residents we had.
Yeah.
And but I agree with you. So how would you? Let's say CDI was the cornerstone of documentation, because right now, I think you'll agree that the training you get from CDI is what, queries? Is that what you get from
Practically, yeah, and our
practically.
attendings may be showing us a couple queries that they're getting.
Yeah,
Like, please change this on your note.
yeah, that's right. But wouldn't it be nice to not just get the queries? It'd be,
Yeah, definitely.
I would think that structuring it. I want to get your thoughts. So that after the first week, our team would give a introduction to the residents after they were able to settle down and you know where everything is, okay, and then meet with the residents. Like for instance, we had a lunch and learn once a week. Of course, and if they were clobbered with cases, we would postpone that. We bring up some cases that were on the floor that we had to query because I think really what I see, I want to get your thoughts. It's really not about the query; it's about getting it right the first time.
Definitely.
And
Yeah. So, I don't know. Like, this is one thought that I've been having lately. I don't know what your thoughts
yeah,
are
yeah,
on this, but I think that as we move towards more interdisciplinary care in terms of patient care,
right.
rounds with the nurses, with the respiratory therapists, with the case managers, what would be? I think they would have a very important role in giving timely feedback to the physicians in terms of documentation. Because we can just say like, oh, septic shock secondary to this, and in general you will be fine. But then you start getting with the community-acquired pneumonias, and there's a lot of more nuance with the pneumonias
Absolutely.
that could affect your documentation and further down, your billing as well.
That's right.
So I don't know if that's feasible or not.
Well, now, let me kind of run by what we've come up with, and I notice I'm saying we and not myself. So the program that we had, I want to get your thoughts on this. Since you're a resident and you're in the thick of things, okay? So we had multidisciplinary rounds. So the physician advisor would be in the room. Okay, I'm sure you have a physician advisor there at your facility. We would
Yeah.
have the case management director there. We would have different case manager. These were 4 days a week, and we'd have a different case manager at each meeting. But the case management director would be there, and we'd have our UI director there, and we would have the medical director of the hospitalist program, because we had 3 hospitalist programs. One of them was a residence. University of Las Vegas, okay, and the resident would come in to present the case real quickly. Okay, Mrs. Jones, a 75-year-old, we're going to discharge him today. Okay, here's a perfect example. Discharged today. Okay, however, she developed flash pulmonary edema, so we ordered some IV Lasix because the X-ray showed pulmonary edema with pulmonary vascular congestion. I ordered another echo. But what's the doctor read? So we were able to give feedback. Okay, what provisional diagnosis do you have? Okay, because provisional diagnosis certainly count towards your medical decision making from a communication of patient care, but also billing as well. Okay, because just because you're not sure, doesn't mean you can't count that towards your medical decision making. So that's the kind of feedback, and we develop like tip sheets and resources, and that way we're providing immediate feedback to the resident. Of course, every time you pick up a chart, there's room for improvement, right?
Yeah.
And we don't want to be nitpicking, but we try to provide that. I think that would be helpful. Do you agree?
I think so.
In your program?
So yeah, there is such a thing, but so you would come to them.
Right.
So how it would work?
We would be in a room, and then the resident would come in. Okay, so we would page when the resident. Okay, it's your turn, and they say, "Well, I'm still with a patient right now." Then we go to the next resident and page them. So they say, "Okay, I'll be there in 2 minutes." So then we would make it through the list. Okay, obviously, if you're dealing with patients, patient care first, right?
Yeah.
So we would go to the next resident, and they really appreciated that because we can provide. If you say pulmonary edema, that's really an abnormal radiology finding. It's not really a diagnosis, right?
Yeah,
Okay,
definitely.
what is the contributing? What is the etiology? What are the contributing factors? Why do you think? You know, and I think that's really important today. You know, with the new January 1st E&M guidelines for inpatient. Now you have a medically appropriate history and physical. So what counts? What really counts? Medical decision making, right? And that's not the crux of medicine. Am I wrong?
Yeah,
That's why you're devoting what 10 years of your life,
definitely.
and now you got the fellowship in critical care. So there goes 2 more. What 2 years? Am I
2 more
right?
years.
How many more years?
2 more
Two
years.
more years. Okay, 2 more years of debt. But I think would that model be something that you think would be feasible with CDI driving the ship?
Yes, the we have that currently, but the main focus, due to limited beds, has been, and that's been since COVID, and I started in 2020 with
Oh,
COVID
right in the middle of it. Yeah.
residency. So the issue has been that people are a lot sicker and are sicker for a longer time. So now we have limited availability of beds. So it's more of a disposition type of meeting to help guide in terms of.
Yeah, and that was one of the things we discussed, okay, because then the case manager would say, are they ready to go? What's holding them up? Is there something we
Mhm.
can do? Do we need social work? Do we need the insurance case manager to come on site? I think, but to the extent that we can provide this maybe a minute feedback, like, doctor, what were you thinking this? Oh, yeah, could you please write it down? This is why. Okay, we wouldn't spend 5 or 10 minutes because we don't have 5 or 10 minutes.
Yeah.
But they would have like 5, 6, 7 cases, and some of them we didn't have any comments, and a lot of it is because we actually reviewed the record ahead of time, so we would have our questions ready to go. Okay, I think I really think that's a better model. And then having these educational sessions like we did, lunchtime because if you provide food, residents will be there a lot of
Yeah.
times. The good food, not they're looking for some decent food, right? Pizza. One guy said, "Where's the steak?" Say, we don't serve steak at lunch. But I'm thinking that would be a great way to help residents get ready, prepare, because a lot of the residents I deal with say. Because I work with several clients, and the residents say, like Mississippi, we want to get ready because we don't want to fall flat on our face when we go out on our own, because that's where you're putting your own E&M down, right?
Exactly. Yes.
So let me ask a question. You feel like you're prepared for the next phase from a documentation perspective? Not that I'm putting you on your spot.
Or you kind of are, but it's okay. So in terms, I considered before deciding to do in critical care,
Yes, sir.
I considered doing hospitalist.
Oh, great.
Um, so if I was gonna be a hospitalist at this moment, I think documentation would be my greatest weakness, honestly.
In terms of what H&Ps, or just meeting the standard of what the standard is, or maybe putting too much information in the H&P.
I think putting too much information, going through that transition of, see, from resident documentation to satisfy the attending to simply the real life having to communicate from documentation perspective to coders.
Right.
I think that would be the biggest transition. In terms of medicine, I think medicine is kind of standardized, or at least the education in medicine is standardized, that no matter where you get, you kind of get the general gist of what medicine treating patients is, but more of the specifics of clinical documentation. I think the residents that you found yourself with, the R3s, I think they are not few and far in between. I think there's a lot of us just like them.
Right. And I agree. And there should be some type of formal training from a not from a coding perspective, because coding. Yeah. My philosophy is, or my thought is, if you meet the standards of documentation, what's interesting, Dr. Aragon, is that is that the new E&M guidelines, well, they had the 2021, so they're not really new, but they're new to inpatient and observation. And I think one of the areas the AMA says that the guidelines are not the standards of practice or standards of documentation. However, I was thinking the other day when I was at the gym, riding the bicycle for 90 minutes, you get kind of bored, so you think of something else besides music, right? And
Yeah.
I was thinking, it's not intended to be the standard of documentation. These are just the coding guidelines. However, I do feel that they can serve as the standard of documentation because they say what? Medically appropriate history and physical. Who determines that? Not the insurance company, the resident or the physician. Doesn't matter what specialty you're in. Critical care, pulmonology, infectious disease, right? History of present illness. You got your PFSH review of systems, and I think it's really beneficial because now you're not sitting there having to remember, okay, I need 10 out of 10 on the review of systems, right? I need 8
Yeah.
plus on the physical. No, do your medically appropriate physical exam. Don't be doing body areas or organ systems just to get a number, okay?
Yeah.
Then the piece is the history of present illness, which is crucial for medical necessity. It's telling that patient story adequately. There's 8 elements, okay, so now you need to have at least 4. That's what I try to let physicians know. Can't have a story of a good patient describing, reflecting, accurately portraying a severity if you don't have 4 elements. Okay, then you go back to your medical decision making. And if you think about medical decision making, I think this is where CDI certainly can play a really crucial role. Is that okay? One, the number and complexity of problems addressed. So, what does the AMA define as addressed? Well, they tell you in the code book, right? Then they give you the amount and complexity of the amount and complexity of data analyzed, reviewed, and interpreted. I think that's the biggest deficiency in documentation is the epic, whatever you have, blows in the labs, but no one makes any comments on them. They're just sitting in there out like naked, right?
Yeah.
And then you get to the risk of the diagnosis. Okay, so that's where provisional and definitive and social determinants of health. So to me, that's the standard. We can start from day one, or not day one, 2 weeks into the R1, okay, and reinforce that. Then I'm thinking the residents will be better prepared for the real world. Do you agree?
I definitely agree. Yes, I think we need to be a little bit more proactive on this.
Yeah. So, any comments, suggestions? What would you like to see from a CDI perspective before we close out?
I think more CDI involvement would be important, but I think they don't really appreciate how important they are or how little we know about them as residents. This is me simply, I knew about them. One, during my MBA, they told us about this, like there's this whole other aspect inside of medicine that they don't teach us in medical school.
Yes.
So coming into residency, I kind of knew who they were and what their role was, but they still hadn't been very active until 7 months in when we had this meeting, this presentation of appropriate clinical documentation. So I think they need to be more aware of how important they are in our development and our as we grow as residents and as future physicians.
Yeah, and would you say that it'd be if they had the same knowledge as, and I'm not trying to brag, but if they had that same passion and knowledge base, that would certainly be helpful in instilling in residents the knowledge, I think, and the confidence to be able to document appropriately. Well,
Yeah.
I think this certainly was a great presentation. So you're starting your critical care when in June, July.
1st. July 1st, yeah.
So you're all set and know all the rules about critical care billing, right?
No, not really, not at all.
Reach out to me and I can help you with that. Okay. So
Awesome, thank you very much.
because critical care, what's nice about critical care in closing is, and this is for CDI as well, is that You don't have to. You don't have to meet any of the same medical decision making. Well, you do, but it's really only based on time. And certainly one of the 30 to 74 minutes, and an additional 15 out of 30. You have to go 16 minutes out of out of 30 to 74. So one of the things that I see is that unless you have a critically ill patient described and well told, with imminent life-threatening organ failure, okay, acute respiratory failure, stroke with hemorrhagic stroke, okay, or pneumonia with acute on chronic respiratory failure, unless you have that particular description, then the pay is going to say that's not critical care. So spread the word if you see any critical care. Dr. Aragon, thank you so much. I wish you continued success in your program. And I know you're going to be doing well in critical care. So this concludes our first podcast of Clinical Documentation Intelligence Podcast, also known as the podcast for the CDI. And thanks very much. Please be on the lookout, because we're going to be doing these podcasts regularly, trying to invite interesting, highly informative physicians, residents, physician advisors, CDI. So thanks again, and keep up the great work. Bye-bye.